The main reason is that upper gastrointestinal symptoms that suggest gastroparesis are relatively non-specific. Symptoms such as nausea, vomiting, feeling of fullness and discomfort after a meal may not only be caused by delayed gastric emptying, but sometimes they are caused by other problems of function of the stomach. About a third of patients who have these symptoms actually don't have a problem of emptying of the stomach. They may either have normal stomach emptying or, paradoxically, accelerated gastric emptying. And so individualizing the treatment of these patients requires us to know whether they have normal emptying, fast emptying or slow emptying. And among those patients then we can determine how best to treat them. Outcomes of treatment, of course, depend not only on the validity of the tests, but they also depend upon how efficacious is the individual treatment that we use. And regrettably, we don't have very good medications that have a good side effect profile. And so our choices are limited. But that's not to say that we shouldn't treat the patients according to what we identify on testing. And specifically, if we find somebody has fast emptying from the stomach and causing the same symptoms as somebody who has either normal or slow emptying, it helps us to know that that group of patients do not need a medication that would further accelerate their emptying. Because there is a variation from one day to the other in the results of the test. But there are some tests that are much more valid and much more reproducible than others. And so what we really need to do is to maximize the way in which we test these patients. And there are some very well validated gastric emptying tests using scintigraphy. It's not only a matter of frustration, it's a matter of great disappointment for the patient, and ultimately what we're trying to do is to help the patient. At the present time, I would say that the biggest problem is the validity and the efficacy of the treatments, which needs to be improved. Well, what we do is we work with the patient, work with the dietitians, because we know that there's about a 15 to 20% reduction in the severity of symptoms by simply changing the physical nature of the food they eat. So, for example, blenderizing or homogenizing solids will allow their stomachs to empty better, and that is associated with an improvement in symptoms after they eat. Secondly, we say to patients that there are some of these medications that are going to be efficacious for them, but we may have to try one or another before we actually find the combination of dietetic therapy and pharmacological therapy that works for each individual. So we have to individualize these treatments so that we can enhance the outcomes for the individual patient. It really does make it far more complicated because there isn't a standardized approach and a standardized treatment. But that doesn't mean to say that we throw up our hands in the air and not try to find out exactly what is the problem in the function of the stomach or the intestines, or that we throw up our hands in the air and not use whatever medications are available that could at least theoretically help these different functions. And the functions are not just emptying, it's also the function of relaxation of the stomach, which is important to reduce symptoms after the meal. And the third function is that of increased sensation of the stomach. And so by doing some relatively simple tests, it is possible to differentiate which of these dysfunctions is relevant in the individual patient. I appreciate that doctors are stretched in their daily functions, but I would just remind ourselves that 1 in 5 patients with these upper gastrointestinal symptoms actually has fast emptying from the stomach, and 1 in 3 has a problem with the relaxation response or the sensitivity of the stomach. And by incorporating two relatively simple, non-invasive tests, which are to measure stomach emptying and to measure the amount of nutrient drink that can be ingested without causing very severe symptoms, we can identify the subgroups of patients and then select the best treatment for those individual patients. The next steps obviously have to be to apply these studies, these tests, which have been validated only in a few centers, and then apply them more broadly in gastroenterology practice. And secondly, it's also on the basis of these tests that we should select patients for the different pharmacological approaches so that we can identify which medications work for very specific disorders of function of the stomach. It takes all of the above, and it also requires support from regulatory agencies to identify the patient response outcomes, the design of studies that would lead to regulatory approval of new medications. So it isn't just research and resources that would be provided in the form of new medications, but also a regulatory path that would permit a change of practice based on hardcore evidence.